Yes, start broadcasting. Okay.
Good evening, everyone. Welcome to the Member Appreciation Plus webinar for June. This is Amy Lamb, your AOTA president. You may have noticed that we are using a new webinar platform this evening. There's several new features for it. One, just to draw your attention to, on the far left, there's a tab for event resources where you can find our slides for tonight. Also, I wanted to let people know that on Friday you will receive a link with the recording of tonight's presentation. And another benefit of the new platform is that now the CE certificates are automatically generated following the webinar, so there is no wait time. However, you must stay on for the entire webinar until you see the pop-up screen that says the webinar is now over. Please do not exit the webinar prior to viewing that pop-up screen, or you will not receive an email containing the link to your CE certificate. So make sure that you stay on until you see that the webinar is now over pop-up. Tonight I have Christina Metzler joining me. She is AOTA's Chief Public Affairs Officer, and she's joining me to talk about some of the resources that we have for you at AOTA regarding readmissions. As some of you may be hearing at your facilities, readmissions have been under focus as it pertains to quality of care, cost, and overall health of Medicare beneficiaries. And so tonight's presentation is regarding an educational tool for the OT practitioner regarding occupational therapy and readmissions. So the purpose of this tool is to assist occupational therapy practitioners as you share information regarding the value of occupational therapy with key stakeholders. We know that as OT practitioners, we need to stand up and take an active role to promote the profession and make sure that we're showing our distinct value in the various healthcare settings. If occupational therapy isn't promoted, then there's a risk of reduced services for our clients, and that will impact their ability to be as independent as possible. All settings are being monitored for outcomes, and a particularly important one in many settings is the frequency of hospital readmissions. So research studies, quality improvement data, and quality measurement can have a powerful role to promote the value that occupational therapy can bring to the hospital, to the healthcare system, and the therapy practice administrators as well. This is a two-part PowerPoint tool. So part one, which is what I am going to be doing here in a minute, is an educational presentation for the OT practitioner regarding occupational therapy and readmissions. Part two is a PowerPoint that can be taken by the OT practitioner and used at individual facilities, and it contains a good amount of information for you in the following areas: the Center for Medicare and Medicaid Service Readmission Tracking and the Potential Impact of Occupational Therapy, the demonstration of the value of occupational therapy through use of current evidence and literature-based solutions, CMS tracking of hospital-acquired issues and the potential impact of occupational therapy. And then the references are presented with the slides as well at the end to allow them to be remembered as well. So OT practitioners will need to be knowledgeable about both the parts 1 and 2 in order to be able to present at individual facilities. And in part 2, which is where you'll be hearing Christina Metzler this evening, you're going to see some red text, and that red text can be customized prior to the presentation by the OT practitioner for your stakeholders. So part 1, looking at occupational therapy and readmissions. And this is important information for the people who will be presenting the part 2 to others within your organization. Some preparation is required before you meet with administrators. One, at your facility, there's certain things that is vital to know. You need to make sure that you know the mission and goals of your facility as a whole, as well as the individual OT department and how you can and how this works, and using occupational therapy can help to meet the mission and goals of the facility as a whole. You want to make sure that your ask is aligned with those. And you also want to know what external threats and opportunities might be up there. And so we'll explore some of those, but you want to know facility policies, what the CMS rules are, different things along those lines so that you can know where the opportunities are for occupational therapy with regards to readmissions. You also want to be aware of what internal threats and opportunities. They might have questions about cost concerns, and that's where some of the cost effectiveness studies that we can talk about this evening can be very helpful for you as you promote occupational therapy's value. Typical administrator concerns that people have experienced in the past, improved patient experience and satisfaction. This is all of our facilities are looking at patient experience and satisfaction, and so people are really wanting to think about how do we better make the patient experience better. So that's one that administrators are oftentimes concerned about. They're oftentimes concerned about length of stays, and they want to keep those length of stays down, especially in hospitals. We want to get people out as soon as they are able. And the third is really that quality and outcome measurement and making sure that we're providing the right services at the right time by the right provider for the individual who is receiving services. Another thing that you'll want to do is identify data on your facility related to the issue with regards to readmission statistics. So you're going to want to know, where does your facility sit with regards to readmissions? Also, prior to meeting with administration, it's good to make an appointment so that all of the necessary people can be present. It's great to be able to have a room of people who can ask good questions and hear what other questions are being asked. Also, encourage people to be well prepared and anticipate some people may have negative reactions initially, not understanding what occupational therapy might be able to do with regards to readmissions. But really being able to tailor your response to that will help to decrease any concerns or questions they might have with regards to that. I'd encourage you to bring copies of, or maybe just citations, if you would rather, to the resources that we talk about this evening, because that can demonstrate that you're using evidence to back up what you're saying. And also encourage you to speak with your direct supervisor and your department director as appropriate as you prepare to be able to meet with administrators. During the meeting, some tips and keys that can help you to be successful. One is, we encourage you to provide the presentation for all to either have a hard copy or electronic, whatever is preferable, but encourage you to make sure that they have that presentation accessible. Be prepared with written documents in case technology fails. We all know technology is great, but it doesn't always work the way we would like it to. And so being prepared with hard copies can be helpful. Make sure that you allow some time for questions and answers. So you want to hear what their thoughts are, and that's why you are coming to this meeting so well prepared, so that you can provide them with good answers. You want to stick in the time frame that's provided for the presentation. So you don't want to go over. You want to be respectful of their time. You can agree to come back if you need extra time, or if you need to follow up on something. If somebody has a question that you don't know the answer to, it is completely acceptable to say, that is a great question. I don't have that information today, but I'll bring it back to you, and then schedule that follow-up. And then ask how any decisions will be made to be able to implement changes so that you can know what to expect. After the meeting, I encourage you to follow up, thanking those who participated. You may just want to send an email. I personally like to do a quick handwritten note. Those are less frequently used these days, and they stand out. So just give a real nice thank you to the people who participated. Report back to your supervisor or department director as appropriate, because sometimes you need to make sure that they're in the loop. It's not necessary until supervisors decide either way, but just making sure that you're keeping people informed is important. If there were questions that need to be answered, making sure that you update those who were in attendance with regards to the answer. You can let people know this is a question that came during the meeting and here's the answer. Sending a nice group email with regards to that can be a good way to be able to make sure that everybody gets that. Contact others. If you're in the meeting and some administrators say, we'd like to have you touch base with this group or some individuals over in this department, make sure that you do that. Be prepared to follow up with administrators on any specific requests that they have that might lead to that ultimate decision being made. And then continue to monitor some of the evidence and research that's happening on these issues, because these are things that are being actively researched and examined within the healthcare community. And so you want to make sure that you're keeping up to date on the current information as it's becoming available. So your goal is to share the evidence with them that we have, and we have wonderful evidence that we're going to be sharing with you this evening that really shows the value of occupational therapy as it relates to reducing readmissions. You're also wanting to explain occupational therapy's role, emphasizing the work that we do in activities of daily living, instrumental activities of daily living, functions, psychosocial. You want to really put that whole picture together for them so that they can understand how occupational therapy is different in our approach. And you want to show that you're on the team for the facility and for the system at large. And that's why the more that we can link our work to the mission and goals of our facility, they do see you as a team player. So, for example, when you are trying to schedule that meeting and you say, I know that quality is important to our facility and that we have goals that have been set with regarding to this area, and I believe occupational therapy can help, and here's how. Or if we have a goal to reduce readmissions, and you say, I think occupational therapy has a role here, and I'd love to speak with you more about what the evidence says to support that, to make sure that they see that you're a part of that team. And this is really where, you are being the OT practitioner advocate. And so I would encourage you, we're going to transition over to Christina Metzler, who's going to go through part 2 of this PowerPoint. But as you share part 2 with your hospital or your skilled nursing facility or your home health or any other administrators, we want to make sure that we're emphasizing that distinct value of occupational therapy as it relates to readmissions and protecting the health and safety of Medicare beneficiaries. We also, this information that can be put together and translated to promote higher levels of quality utilization of occupational therapy as well. And just keeping in mind that in order to present this information, that you need to be prepared by understanding the evidence and understanding the research and the environment and context that surrounds the system and the clients that we're seeing. And so some of those articles are going to be discussed as we move forward through part 2 of the presentation. So with that, I'm going to transition it over to Christina.
Good evening, everybody. How are you? There my picture popped up. I hope everybody had a good long weekend and you're prepared to be innovators. Innovation is the theme of these Membership Plus, Member Appreciation Plus seminars that Amy has instituted. And what we're presenting tonight is an innovative idea to give you tools to be able to go to your administrators and make a case for occupational therapy. What I'm going to show you is a suggested PowerPoint to explain the research that I will go through that shows very positive impact of occupational therapy on this issue of readmission. Before you present this, become familiar with the slide presentation. Make adjustments as you see fit to align it with your facility so that you can be an innovative OT in promoting the value of occupational therapy in this and in other areas where we know that occupational therapy can bring benefit to both consumers directly and their health, and facilities and their ability to be cost-effective and prevent negative consequences. Look at the speaker notes section when you download this. I'll have to double check with Amanda if the notes section will be in this, or if you will have to go to the AOTA LMS system, but we'll provide that information and send you an email. But the speaker notes have some further information. Images or a background can be applied to these slides as you desire, and also individual information on your facility. So Amy's told you about how important the role that you can play as an advocate is, and I'm going to give you the information, the tools, the arrows in your quiver that you can use to make a case for improving occupational therapy's presence and participation in the overall work of the facility, but also in a broader way, in a more comprehensive set of approaches to patient health. So here's just the intro to slide that we would suggest: the impact of occupational therapy services on readmission, benefits in acute and post-acute care. The issue, as you would say in giving this presentation, but I'm going to act as if you are my audience in a facility and just be talking about what the research says. Readmission, as Amy mentioned, is one of the factors that's used by Medicare and other payers to determine the quality of care. It's a proxy for quality. The assumption is if you have certain conditions and you as a hospital or a SNF have a higher percentage of people returning to the hospital than your peers, then maybe there's something you can do better. And what we are suggesting, based on the research we're going to talk about, is that improved connection with and use of occupational therapy can help. As you may know, Medicare reimbursement is moving toward a value-based and incentivizing payment system for all settings in Medicare, trying to promote good outcomes for patients and good use and stewardship of Medicare dollars. Under this readmission issue, hospitals that are found to have a higher than average readmission level for certain diagnoses, they have to pay a penalty. And this penalty is moving toward being applied to other facilities in the post-acute network as well. How does CMS monitor readmissions? CMS collects data and compares the rates. This is a website where you can go to look at what kind of data they can collect and what kind of data is there about your own facility. Well, we will focus on hospitals. One of the studies also references an independent rehab facility. And independent rehab facilities, skilled nursing facilities, home health are all considered post-acute care. And there was a new law passed a few years ago called the IMPACT Act, which requires post-acute care settings to report on readmissions-related quality measures, because they believe this, the post-acute care providers have a role in affecting whether or not patients go back to hospitals. The hospital where the acute incident happens or acute care is provided has an impact, and so does the post-acute care provider. But occupational therapy all along the way is proven to have an impact. So the CMS readmission reduction program relates only to certain diagnoses. In the beginning of this program, there were only 3, but now we've expanded to 6 on the next slide. You can see that they are very common diagnoses, and based on existing data, CMS has established national averages for readmissions for each of the following categories. And they're all in the teens and 20s sort of area. But if you are a hospital that goes beyond those averages for these diagnoses, most of which have a component of involvement by occupational therapy. If your hospital is outside of the norm on the heavy side, then you will be charged. If they go over the expected percentage, they're penalized per readmission. So if CMS expects 20 of 100 clients with a diagnosis of pneumonia to be readmitted, but the hospital readmits 25 out of 100, there's a monetary penalty. This can become very costly. But it has been affected. You can see that for all conditions, there's been a 2% drop. There was a 2% drop just between 2010 and 2015 for all conditions. And you can see how the data breaks out for various of the 6 conditions, the most common conditions. And there is also a link to the full citation of this information. But it's had an effect, but at what cost? It was predicted that in 2017, based on the past few years, 2,000 hospitals will be penalized. And this will total more than $500,000 in penalties. Imagine if they could have saved that $500,000 by better using occupational therapy more effectively and more frequently, they would have saved all of that money. So that's your mission in using these slides, to educate facility managers about the possibilities for changing their readmission rate by using occupational therapy. We're looking at evidence to enable you to carry this message, that there is a relationship between OT utilization and readmission, and also that this may be linked to occupational therapy's emphasis on functional outcomes and functional limitations, as well as social determinants that affect care in the hospital and the success of patients after leaving the hospital. The upcoming slides will examine some of this evidence. There are 3 major studies. The first study was received with a lot of fanfare when it came out in 2016. It used occupational therapy in its title, saying that occupational therapy is the only spending category where additional spending has a statistically significant association with lower readmission rates for the 3 conditions that they examined. And furthermore, this study, while saying that the data showed that spending on OT seemed to have an impact, they also noted that they speculated that the emphasis on functional needs and social needs, which can be, as we'll see in some of the other studies, significant factors related to readmissions. But when they were writing this study, when they were establishing it, their purpose was to provide advice to hospital administrators. And so what we are suggesting with this webinar tonight is that you can be the ambassadors to share this with your administrators and tell people that occupational therapy has been shown to be associated with reductions in 30-day readmission rates for heart failure, pneumonia, and acute myocardial infarction. This was a very significant finding. What they did may be of interest to some administrators, but just simply, they used the 3 admission categories, heart failure, pneumonia, and acute MI, and they analyzed where hospitals spent their money. And they tried to look at relationships with where money was spent and how people were successful in transitioning out of the hospital and not coming back. They looked at 19 categories of spending, and one of these was OT. You can see there they looked at a wide variety of spending in hospitals, which the later studies also looked at. And what they found was there was a significant relationship between occupational therapy and reducing readmission rates. Well, it turns out there was an earlier study in 2014 that looked at hospital practices and tried to identify what about hospital protocols for these diagnoses seem to be related to reduced readmissions. And lo and behold, they also found that hospitals with a higher use of occupational therapy seem to have better outcomes. There were one other factor seemed to be related, and that was the fact that beneficiaries transferred from other hospitals into an acute hospital, they seem to have lower readmission rates. But they definitely found in 2014 that for stroke post-CVA patients, that where hospitals were more using occupational therapy, they had better readmission rates. What were those study methods? They looked again at data for ischemic stroke patients from 5 states. The primary outcome they were looking for was any unplanned readmission within 30 days. That's the window that you're worried about and that Medicare is looking at to establish its penalties. And they estimated the association between practice patterns, like what they were doing in diagnosis, what kind of procedures they got, whether or not people went to intensive care, and therapeutic modalities, including occupational therapy and readmission. Now, this study did adjust for patient factors. There's another study, a third study, which, while it doesn't specifically mention occupational therapy, it is important for your message to your facilities and our message as a profession that being part of a team and having protocols that look at the whole person are critical. So this study analyzed what happened in facilities around discharge and analyzed what seemed to be good practices related to low readmission rates. And they addressed issues of community services, medication reconciliation, and patient education. So they looked at this and they said, well, we really need to have teams and we need to follow certain procedures that would help to prevent bad discharges that resulted in a readmission. This one was in an IRF, and they came to the conclusion that a teamwork approach was absolutely what was necessary. So they came up with this approach called Team Steps, and these steps were followed to best meet the needs of the patients as they returned to the community. They did a gap analysis first to identify what should be done, looking at many disciplines, including OT. They developed the STEPS program, And then they promoted patient involvement with a variety of methods. It sounded very OT-like to me, in supporting people as they participated in their discharge planning. So what they found was that when occupational therapy was part of the team and you use these team approaches to address some of the things that occupational therapy has positive results in, like the transition to using community services, transition to being safe at home, transition to being knowledgeable about how to take their medications and how to fit medication utilization into their daily needs. They found that these areas and this team approach, including OT, was effective. We believe that these pieces of research have application not just to hospitals, but to any settings, wherever you are working. SNFs now have a requirement. They had a requirement in 2014. It's been expanded under the IMPACT Act, and other post-acute settings can be responsible for readmission rates. So all of these approaches, the STEPS program and a team approach to discharge planning, considering factors that occupational therapy has knowledge and skills to deal with, the stroke data that showed that when you increase use of occupational therapy, when you have a high utilization rate of occupational therapy in your facility, those stroke patients tend not to come back. And then the big study that said that of all of the spending categories in hospitals in their budgets, occupational therapy showed the most relationship to people being successful in their post-acute placement. So we think these principles can be applied to any institutional setting and promoted by occupational therapy in all of those settings to improve their role, to improve their utilization, and to allow you to work at the top of your license and provide the best care you can to your patients. Another area that CMS is concerned about is hospital-acquired problems. And a lot of these are related to concerns that occupational therapy has the knowledge and skills, again, to address. Examples of hospital-acquired issues that can be addressed by OT include falls and immobility. We know how to encourage people to pursue their activities, to take care of their ADLs, and we know how to modify environments both in the hospital and when people go home. And then maybe for discussion among us, if you want to ask a question, what do you think? What about these interventions emphasizes the distinct value of OT? What could we say to hospital administrators about falls and immobility and the role of OT? Pressure ulcers is another place where occupational therapy can have an impact. Occupational therapy can deal with positioning, being involved in the ICU immediately after surgery for early mobilization, for education of caregivers, and for self-awareness of patients to be able to participate in their own, in the routines that will help prevent pressure ulcers. Deep vein thrombosis and other related issues are also places where occupational therapy interventions can address these problems of hospital-acquired concerns that Medicare is monitoring. Again, we're talking about early mobilization. We're talking about enabling people to perform self-care appropriately and safely. And we're talking about functional task analysis and intervention to get people back to their routines and what matters to them as soon as possible. What do you think are examples of how to implement these? This is a way that you can make this presentation unique to you and unique to your perspective and your facility. Diabetes is an area that's very important, and AOTA has been working over the past few months to join with the American Diabetes Association to talk about how OT can be more useful to individuals who experience diabetes. Now, we're talking right here about acute hospitalization and what OT can do to help prevent acquired problems in hospitals, and what OT can do to prevent readmissions. And of course, we know so many patients have diabetes as either the main reason for their admission or a complicating factor, comorbidity, related to the condition that they're in the acute facility or post-acute facility for. And we know that OT can be effective at addressing some of the problems with diabetes management, like meal planning, like developing routines to engage in physical activity, by figuring out how best and when and physically how to conduct blood sugar monitoring. And of course, stress management and coping strategies with a disease like diabetes are critical, and who better than occupational therapy to help people to cope with this within their lives. Of course, proper hygiene and enabling the ADL, which is critical for people with diabetes, of foot care, and using occupational therapy strategies to enable proper foot care, as well as compensatory strategies for sensory and particularly visual deficits, and also for motor deficits that may be present in people with diabetes. And when you're giving this presentation, you can talk about what you feel are distinctive OT approaches that can be used to address diabetes in acute care. So modify all of this to make it make sense to you and make sense to your administrators to move toward using occupational therapy. We have our contact information here for Federal Affairs, and you can contact us for any questions or any reactions you get if you are a courageous innovator who will give this presentation in your facility. You can customize these slides, and of course, as Amy was saying, writing thank you notes is important, as well as just thanking the attendees right there and then about their willingness, thanking them for their willingness to take time to think about new ways of doing things. In healthcare, we have to reform, and the way we have to reform is to think of new ideas. This research points us to the idea that occupational therapy can be part of the solution, must be part of the solution. And these slides are intended to help you to convey this message within your facilities to your fellow OTs, or to virtually anybody who will listen. Here are the links to some additional resources on the Medicare website and other websites talking about this issue of readmission. This is a slide with the references for the articles that we've quoted in here, as well as the Patient Protection and Affordable Care Act, Obamacare, which began the readmission reduction program. And you should be able to get copies of these. We're going to try to post them when we get this on the LMS, the Learning Management System at AOTA. So you'll have ready access to them, but you should be able to get these online. This is our last formal slide. I wanted to say that we're very excited about this research and this trend in research. We are thinking about how we can encourage the next steps in research to validate what has been found so far about the relationship between occupational therapy and readmissions. And we want to go deeper to find out what exactly is it that occupational therapists are emphasizing, whether they're just in general in a hospital, whether they're working with patients who have experienced a stroke, or whether they're working as part of a team, as in the last article. This is what we want to find out. We want to know, and of course, if you have thoughts about this, we want to hear from you too. I see we have a question already that I think we need to state OT's use of activity analysis and how we can modify each person's need and how we can increase activity to get results. I think that's a very good question. Amy, did you have a comment? I'm going to keep going on the questions.
Yeah. Chris, I would just add one thing to that. I think that is an excellent point, and I think we do have the ability to kind of emphasize that, and that would definitely be, I think, a key point to be able to bring up when you're with administrators. Would you agree?
Oh, I would definitely agree. I would say also, I hope I'm not being presumptuous, but you could apply activity analysis to the discharge process of your hospital too, and you might discover some things. You know, activity analysis is just not used for your clients, but you can apply it to systems too.
So, Chris, another question that came through was, how would one initiate interest on behalf of the OT department in acute care to join the wound team when at my facility? There are wound care MDs who manage this. Would this be an appropriate topic that they could bring up with them?
Oh, I would think so, because I think, you know, that how a patient addresses their personal issues when they get back home, how they care for themselves, how they pay attention, all of those things are critical. And so advocating the relationship between readmissions and wound care, and that OT can have a relationship there. If you've got an opening there, wherever you have an opening, that's where you need to go. If you want to make a connection with wound care, if you want to make a connection with your diabetes team, if you want to make a connection with your neurological team, wherever you feel like you can make a connection, this is where you can take this information and bring up the possibility of increased involvement in occupational therapy in inpatient care, as well as in discharge planning. That's an important distinction I want to make about the three studies. The first study looked at where hospitals currently spend money and showed that where hospitals spend money in OT, that seems to be related to them having good readmission rates. So it shows that spending on OT is a positive thing. The stroke showed that the stroke study showed that using as part of the protocol, having a high utilization of OT within your hospital. And I want to note that that study showed that not just individual patients receiving OT, but just a higher rate of utilization of OT within a hospital seemed to relate to better results on readmission for patients with stroke. And the third one talked about how OT needs to be, how you need to have a team addressing discharge in order to address readmission rates. So we're talking about generally providing OT in the facility. We're talking about directly spending on OT for each beneficiary, and we're also talking about OT being part of the team. All three of these areas show that OT is a critical component to be used by hospitals and other facilities to make themselves better and to make them better health providers, better achievers of health for the patients that they see.
Thanks, Chris. And I did want to point out, we had one of our participants tonight point out that the Rogers study has a variety of things that it indicates that really represent the distinct value that occupational therapy brought to the table. And so we would encourage all of you on tonight. That would be a study that it would be one of those things that you would want to read before going into any sort of a meeting, so that you can be well versed in what they are highlighting and what the evidence is supporting. And they spoke to the home safety assessments, and with regards to prior to discharge, they spoke to modifications, recommendations for training caregivers, and they spoke to, determining whether a patient is ready to live independently or if they need a further level of care. And so they spoke to a variety of things. So we would just really encourage people to make sure that you read those as you prepare for going in and doing those presentations. Another question, Chris, somebody wanted to know if they could take the presentation to adapt it into an educational poster at an OT state conference.
I think this would be great. If we would get a volunteer, we'd be happy to work with you, walk you through this. And I also want to say I'm taking to heart the suggestion that we really need a slide to show those 6 areas in the Rogers study. I think that's a great suggestion. Thank you very much. It takes a village. We're all in this together, and that's why we want to hear from you.
Well, and I think, too, sometimes, and I know, Chris, you and I have talked about this before, but sometimes when you're developing something and you're so into it, you really, you need that fresh set of eyes. And so, we've had other people look at this, but we do appreciate that feedback. So thank you for bringing that up. Another question, Chris, with regards to, is there any research that compares dollar to dollar the cost for providing OT compared to the penalty for readmissions?
No, there hasn't been anything done, but I think that the Rogers study points the way to that. It points the way to two or three follow-up studies, and I think there's a question on what happens what about in the community? What's the role of OT in the community? I think it points toward more research that we need to look at comparison between the provision of OT which is covered as part of the DRG. It's covered, and in a skilled nursing facility and home health, it's covered as part of the benefit. We can see that the relationship is there, but dollar for dollar, yeah, that would be a great study to look at how much, if you spent X dollars on OT, then you would be able to save X dollars on your penalties. But I think what the real message is here is to integrate OT better into the community that is the hospital or the SNF or the home health provider. Because it is in working together and everybody doing what they do best, that's the way we will have the optimum outcomes. And I'm seeing that somebody is asking whether we are recommending that you utilize case studies. If you have any patients that you know of that, when they were discharged, if you looked at them on paper, it might have looked like they might not have they were probably likely to come back pretty soon. But you as an OT intervened, or that your discharge team worked with OT to be involved in a case, and the person actually didn't come back, despite evidence that might have shown that they would likely come back. I think those kinds of things are very good, and certainly if people are interested in this, we can begin to try to gather case studies from people like yourselves and put those together in a portfolio that speak to specifics about how occupational therapy can be integrated into acute care, post-acute care, and discharge planning to affect readmissions.
And I would also just add to that we know that stories sell in a lot of ways, and so the story brings the evidence to life. And when you can use a case study from your facility of a client that perhaps you served and those sorts of things, it really brings this issue it personalizes it. And so I think those are great ways to be able to really drive it home, especially for administrators and talking about the people that you serve in the community. So I love the use of case studies. So it's a great way to be able to just enhance the dialogue even more.
And the second part of that question was related to what aspect would you focus on most? Decreased cost, long-term quality of life, OT interventions during the stay. I think anytime you're making a presentation, you have to start with what you know and what you believe and what you've seen. So what do you feel would be a message that you want to be passionate about so that you can express that passion? And also going back to Amy's slides, think about what matters in your facility. You know the people you're going to be talking to. You know what they care. You've been listening and you've been hearing what do they give messages to employees about? What do they talk about in the employee newsletter? What matters to this particular hospital? What do they try to put out in their press releases? And how then can you translate that, knowing what they're interested in, back to your presentation about promoting OT? It's all, taking in the entire context and then task analyzing it and analyzing it in other ways to focus in on what's going to matter to your particular facility and facility managers. You're dealing with people, so figure out what they're interested in and then speak to that.
And Chris, you talked about community, and there's a question there about envisioning our role in community-based OT for wellness after discharge, perhaps for a private practice. And I think that this is an area where occupational therapy has great value and has great potential opportunity to be able to help people to be well with whatever conditions they might be dealing with in their daily life, and to do that in their natural setting in their community to help prevent readmissions and discharges could be a really strong potential partnership for the future, and a role for occupational therapy for sure as we think about how to be able to enhance our value.
And I think too, facilities and health systems are beginning to realize that they can't stop their care at the doorstep of their facility, that they are going to have to start paying attention to wellness, home safety, functional participation in life, getting people back to work. All of these things are going to have to be part of what the overall healthcare system pays attention to. So I think there's going to be great potential, not only for private practitioners out in the community, but for the practitioners in hospitals and in other facilities to expand their role. Someone mentioned earlier a pre-discharge home evaluation, which I've always thought was the best thing since sliced bread that an OT could do. And I know there are some restrictions on that, but let us know. Have you done that? Have you observed that that's been useful? Are you allowed to do that? Are there restrictions? Let us know what you're seeing out there about this, because we see the research, but you see the reality. So let us know. We gave you the emails earlier on the slide, so let us know what you think.
And I think, too, when people are able to tell us what obstacles that they might be experiencing. For example, if you're trying to do the, OT does the home assessment prior to discharge, and you're hitting obstacles or roadblocks, helping us to know that knows how we can help you prepare to, advocate, and how we can also, look at if there's any policy things that are perhaps in the way that we can help to be able to navigate some of that as well. So that's a great piece of advice as well, Chris.
There's a couple of other questions. I want to I want to come to the EI question at the very end, Amy. There's a question on early intervention. But someone asks if we think that use of OT in a facility equates to use of OT in the home. Well, equate, if you're asking, is OT in home health effective in preventing readmissions, I would say absolutely yes. I don't know that the research that we just looked at did not specify that, but I would say that the home is the natural environment for OT, and home care after an acute episode or after a rehabilitation episode is going to be critical to getting people. So I'm not sure what you mean by equate, but I would say it's got to be as important in keeping people from going back into the hospital as it is in a SNF or in an acute facility. And then there was also a question about a list of standardized and non-standardized measuring tools and assessment tools. AOTA has a full book on these. It's a big, heavy book, but I'm sure you can download it on assessments that are used in OT. And if there's a particular one that you're interested in, we have been trying to provide guidance for people because of the new evaluation codes, which are for Part B Medicaid, Medicare, but there is some information in some of that training, I think, on some assessment instruments. And then before we end, we have a pediatric practitioner on the line tonight and wanted to know if there was research on the effectiveness of occupational therapy in early intervention. I believe AOTA has a practice guideline on early intervention. So you mentioned particularly applied behavioral analysis as a challenge to payment and in time allotted for intervention with children with autism. We are working on this in a variety of areas. So if you want to contact me about early intervention, you have my email up there, or contact one of the other policy divisions in AOTA. We can get back to you.
Yeah, and we have somebody who shared with us that they do home evaluations when leaving the SNF, and that it's been very helpful for them to set up that good transfer home. And they've also done some working with the community to be able to make ramps and get equipment at home along with home health. And I think this is a really great point that we want, people to think about, is that, when we're showing our value, people not only clients benefit from it, but their caregivers benefit, the community can benefit, and the quality of life is really enhanced all the way around. And I think it's important for us to think about the ways that we can help to improve the quality for the client, as well as the cost effectiveness and the quality for our systems and organizations as well, because we know that that's going to be a critical piece moving forward. Any last thoughts, Chris?
No, just I want to importantly say that Professor Catherine Mariano from Quinnipiac University was instrumental in helping us actually put this together. It was an idea that we had, and it was through Professor Mariano's hard work that we actually got this on paper and are able to present it to you tonight. And so I want to thank her.
Thank you very much. And I want to thank some of we ran this presentation through some practitioners who are currently working in hospital systems as well, and we appreciate them looking at it with their eyes geared towards the readmissions that they've been having discussions in their facilities as well. So again, thank you very much, everyone. Please remember to stay on until the end when you see that pop-up screen that the webinar has ended, and that will trigger that automatic certificate to be sent to you. So thank you again for joining us, and we hope that you join us again next month for in July for our Member Appreciation Plus webinar as well. Have a good evening, everyone.
Thank you, Amy.
Thank you, Chris.
Thank you, Amanda, who is our technical person.